This PowerPoint presentation will cover seizure disorders and analyze seizure disorders as they relate to intracranial regulation. Seizures are periods of abnormal electrical discharges in the brain that may cause involuntary movement and/or behavior and sensory alterations. The involuntary movements may encompass the whole body or just certain areas, such as the right arm. These involuntary movements are what most people think of when they think about seizures. However, seizure activity can manifest as altered level of consciousness, changes in behavior, or sensory alterations that only the patient can notice. An estimated 2.2 million people in the United States are affected with seizure disorders. Seizures can happen to anyone at any age, but they seem to occur more frequently in older adults and younger children. When seizure activity becomes chronic with recurrent episodes secondary to a central nervous system disorder, the affected individual is said to have epilepsy. Now we'll talk about the pathophysiology of seizures. Seizures are believed to be the result of abnormal, excessive, concurrent electrical discharges from the cortical neuronal network of cells on the surface of the brain. Chemical changes in the neurons create an electrical negativity that enables the transfer of information between neurons. When an excessive number of these cells become excited, they discharge abnormally. These cells may be triggered by environmental or physiologic stimuli, such as emotional stress, anxiety, fatigue, infection, and metabolic disturbances. Acute insults such as central nervous system infection, hypoxia, and brain trauma are the most common causes of seizures in children. Most seizures last between 30 seconds and 2 minutes. Now, focal seizures are also called partial seizures, and they occur when abnormal electrical activity is contained to a limited area of the brain. They can be classified as focal aware or focal impaired. Focal aware seizures do not affect memory or awareness. In contrast, focal impaired seizures can affect behavior, awareness, or memory before, during, or after the seizure episode. Focal seizures can sometimes turn into generalized seizures, which affect the whole brain. This process is called secondary generalization. In contrast, generalized seizures are caused by abnormal electrical discharges that originate from both hemispheres of the brain. When people think of seizure activity, most think of the dramatic tonic-clonic or grand mal seizure. Although this is an example of a generalized seizure, it is not the only presentation of generalized seizures. Generalized seizures may also manifest as a blank stare, brief muscle twitches, or muscle stiffening. What causes seizures? Some seizures are idiopathic, meaning they are not provoked by known stimuli. Genetic factors may lower the seizure threshold by making brain cells more vulnerable to abnormal electrical discharges. Acquired seizures may be caused by underlying pathologic conditions such as trauma, infection, hypoglycemia, hypotonic dehydration, electrolyte imbalances, endocrine dysfunction, toxins, tumors, or lesions that may be manifested at any time. Febrile seizures usually occur in children as a result of a rapid temperature rise above 39 degrees Celsius or 102.2 degrees Fahrenheit rectally, often associated with an acute illness. Most febrile seizures present as generalized seizures and last only a few minutes. Sometimes the fever can occur a few hours after the seizure. No evidence of intracranial infection or other definitive cause is found. Febrile seizures usually occur in children between the ages of 6 months and 5 years old, peaking in incidence during the second year of life. Infants and toddlers have a lower seizure threshold than adults, so they are more susceptible to seizures from minor stimuli such as fevers. There is often a family history of febrile seizures. In addition, children who have one febrile seizure have a 40% chance of experiencing more febrile seizures, especially if a relatively low temperature accompanied the seizure. Okay. Now let's talk about risk factors for seizures. The lifetime prevalence of epilepsy in children is 10 per 1,000 or 1%, with 6 per 1,000 or 0.6% reporting a currently active seizure disorder. Prevalence is higher in low-income families and in older male children. In addition, about 1.8% of adults age 18 and older have had a seizure disorder, with 1% reporting a currently active seizure disorder. Other risk factors include being an infant who is small for gestational age, the presence of underlying neurologic conditions, brain tumors or infections of the brain, stroke, cerebral palsy, autism spectrum disorder, family history, or abuse of drugs. Children who have a seizure disorder are at higher risk for comorbid conditions, including depression, anxiety, attention deficit, hyperactivity disorder, ADHD, developmental delay, autism spectrum disorder, and headaches. They are also more likely to have to repeat a school grade, have social difficulties, and have unmet medical needs. Everyone has a seizure threshold. When this threshold is exceeded, a seizure may occur. Some individuals have abnormally low seizure thresholds, increasing their risk for seizure activity. Others may experience seizures as the result of a pathologic process such as epilepsy. Prevention of seizures is difficult, but there are some steps individuals can take to reduce their risk for seizures or reduce the frequency of seizure activity. Individuals with epilepsy often experience seizure activity upon exposure to a trigger. Triggers may be individualized. They may be odors or perhaps flashing lights. General triggers include fatigue, hypoglycemia, fever, alcohol, hyperventilation, menstruation. Individuals who are able to identify triggers may succeed in reducing their frequency. Maintaining good self-care, such as maintaining the therapeutic regimen, avoiding alcohol, eating properly, balancing rest and activity, is important for individuals with known seizure disorders. Certain drugs as well may predispose people to seizures. Alcoholics who attempt sudden withdrawal or engage in heavy binge drinking may experience seizures. Other drugs, such as cocaine or ecstasy, can cause a seizure episode in patients who do not have a seizure disorder. The symptoms that occur with a seizure episode are important to note because they play a critical role in helping define the type of seizure and guide treatment options. The initial manifestations of the tonic phase of a generalized seizure are unconsciousness, and continuous muscular contraction. The basal metabolic rate rises during the peak of seizure activity, increasing the body's demand for oxygen and glucose. The patient may become pale or cyanotic as a result of hypoxia. The patient may also become hypoglycemic if glucose demand is excessive. The tonic phase is followed by the clonic phase, which is characterized by alternating muscular contraction and relaxation. During the post-ictal period following seizure activity, level of consciousness is decreased and the patient is often sleepy but arousable. The length of the post-ictal period varies. The exact symptoms of a seizure depend on its type and the area of the brain from which the abnormal electrical discharges originated. Tonic-clonic seizures are the most common seizure type in children, characterized by alternating repetitive tonic-clonic activity. An aura may provide an early warning sign, especially for focal seizures, and may manifest as any type of sensory disturbance such as auditory, visual, or abdominal. When patients recognize the pattern of an aura, they may have time to avoid injury by getting to the floor. And then we see on the other side of the slide the term automatisms. Automatisms occur most commonly with focal seizures. They are unconscious movements such as lip smacking, picking at clothing, or other repetitive motions that may resemble tics. Patients experiencing automatisms are usually unaware of them after the seizure activity ends. Laboratory tests that may be ordered for patients who are experiencing seizures include a complete blood cell count, the CBC, blood chemistries, urine culture, and lumbar puncture. If the patient is taking any anticonvulsants, the serum drug level is monitored regularly. An EEG is usually ordered with the first occurrence of seizure activity, and it may be performed under conditions that lower the seizure threshold, such as sleep deprivation, hyperventilation, or exposure to flashing lights. EEG testing may be done either one time or over several days using a portable monitor. An EEG is often performed at a follow-up visit between seizures. An example of what an EEG reading looks like can be found in your textbook on page 761 or figure 11-15. A lead level toxicology screening and radiologic tests such as a CAT scan or MRI and angiography may be performed to identify cerebral lesions or metabolic disorders in the brain. If a patient fails drug therapy and continues to have seizure activity that interferes with daily life, surgical intervention may be considered. Seizures that cannot be controlled are called intractable seizures. These seizures occur in approximately 30% of patients with a seizure disorder. Surgery will be considered only if the area of seizure focus, where the seizure activity starts, can be identified and is not responsible for any critical functions such as movement, sensation, or speech. The evaluation and diagnostic testing involved in determining whether a patient is a candidate for surgery is quite extensive. There are three main types of surgeries used in the treatment of seizure disorders. The most common type of surgery is a resection, in which the section of brain tissue that has been found to be the source of seizure initiation is removed. This can include a lobe, a portion of a lobe, or even an entire hemisphere of the brain. A transection interrupts the nerve pathways by which the seizure impulses are transmitted through the brain. One common type of transection is a corpus callosotomy, in which the neural connections between the right and left hemispheres of the brain are severed. The third type of surgery involves placing a vagus nerve stimulator in the chest. And this procedure has been approved for patients who are age 12 and older and have focal seizure disorders. Anti-seizure drugs can reduce or control most seizure activity. The goals of medication are to protect the patient from harm and to reduce or prevent seizure activity without impairing cognitive function or producing undesirable side effects. The lowest possible dose of a single medication that will control the patient's seizures should be prescribed. Often, however, several medications must be tried before the most effective one is identified. In some cases, a combination of drugs may be needed to manage the patient's seizures. Status epilepticus is a continuous seizure that lasts for more than 30 minutes, or a series of seizures during which time consciousness is not regained. Dilantin, also called phenytoin, is an example of an anti-seizure drug. These drugs act in the motor cortex of the brain to reduce the spread of electrical discharges from the rapidly firing epileptic foci in this area. These agents control seizures without impairing the normal functions of the central nervous system. Now, note evidence of central nervous system side effects such as blurred vision, dimmed vision, slurred speech, nystagmus, or confusion. Nurses should monitor for those side effects. In the patient taking Dilantin, gingival hyperplasia may be noted. Okay, so of course, mouth care, preventative dental checkups, and good oral hygiene will be very important as well, including the use of a soft toothbrush because of this gingival hyperplasia. And here you see a picture of what we're referring to. Again, they're going to need to use an alternate birth control method if they are female of childbearing age when they are taking Dilantin, because it is teratogenic and it can also lead to neural tube defects. Another anti-seizure drug that is used to control seizures includes Tegretol, also called carbamazepine. And this is used to stop seizures before they ever start. Okay, it is an important anti-seizure drug used prophylactically to protect a client with known seizures, and also for relief of pain from the neuralgias that occur. So when giving a patient Tegretol, watch for side effects such as drowsiness, nausea, vomiting, blurred vision, and headaches. And they also recommend not giving the medication with grapefruit juice. And do not stop these medications suddenly. They should be tapered off this medication. So decrease the dosage gradually. And then there are 3 anti-epileptic drugs that we need to be aware of as in nursing. They're on this review slide. We already talked about Dilantin and Tegretol. But there's a third one that you need to know, and that is valproic acid. It's also called Depakote or Depakine. Okay, and they all work differently, but they're all used in the management of seizure activity. Again, it tells you down there the main things to look for with each of these 3 anti-epileptic drugs. Dilantin, you need to watch for the gingival hyperplasia and bradycardia. Tegretol can lead to visual problems, ataxia, and vertigo. And valproic acid can lead to GI upset and hepatotoxicity. Generally, when this use and treatment of seizures with these medications fail, it's typically because the patient has not been compliant with their medication. Okay, so it is important to routinely do drug levels on these medications. They have a very narrow therapeutic index, meaning that we don't want it to, we don't want it to drop too low, because then it's not effective in preventing seizures and controlling seizures. If it goes too high, then the patient would be at a toxic level. So it is important to monitor those drug levels. Now we would like to go on and talk a little bit more about status epilepticus. We said already that it's a continuous seizure. That means that it lasts for more than 30 minutes or a series of seizures during which time consciousness is not regained. Status epilepticus requires immediate intervention to preserve life. Establishing and maintaining the airway is a priority. A solution of 50% dextrose is administered intravenously to prevent hypoglycemia. Diazepam or Valium is given intravenously, or lorazepam, which is Ativan, is given intravenously, and if necessary, the dose is repeated in 10 minutes to stop seizure activity. Phenytoin or Dilantin is administered intravenously for longer-term control of seizures. Phenobarbital may also be administered to patients in status epilepticus. If seizures continue, intravenous general anesthesia using propofol, which is Diprivan, should be considered. So we have these various medication treatments for the different stages of status epilepticus. Okay, certainly if that seizure is lasting more than 24 hours, that's a refractory status epilepticus, then we need to use anesthesia on these patients. Okay, so do be familiar with the different types of medications that we can use intravenously for status epilepticus. Seizure disorders can strike any individual during the course of the lifespan. Epilepsy can be present from birth or develop at any point during an individual's life, or it may develop because of a secondary intracranial process such as brain tumors, injury, or increases in intracranial pressure. Every year, more than 1 in 1,000 individuals with epilepsy experience sudden, unexpected death. Individuals who are at greatest risk for sudden, unexpected death in epilepsy include those with poorly controlled seizures, frequent seizures, and generalized tonic-clonic seizures. So let's look at seizure disorders in children. Children with febrile seizures are usually not treated with anti-seizure medications at the time of the seizure because febrile seizures typically abate before arrival at the emergency department or clinic. Tylenol or acetaminophen is given to lower the child's temperature. Long-term anti-seizure medication use is not recommended for simple febrile seizures. Following medical evaluation, the provider may suggest administration of antipyretics at home when fever appears, because children with a history of febrile seizure are at increased risk for having another episode. A head CAT scan and EEG, usually with sleep deprivation and flashing lights, is typically done to rule out a pathologic origin of a seizure that occurs in a child with a fever. Any child with a generalized seizure lasting longer than 10 minutes needs to be monitored for electrolytes, glucose, blood gases, increasing fever, and abnormal blood pressure. Most seizure disorders are managed with anti-seizure drugs, which may be given intravenously or rectally. For children, a single medication, that's monotherapy, is preferred for seizure control to minimize the potential for adverse effects, such as sleepiness and difficulty with speech. An additional anti-seizure drug may be used only if seizure control is not achieved with the first medication. The child should be monitored for continued motor activity and the potential for status epilepticus. The post-ictal period ranges from 30 minutes to 2 hours. The primary healthcare provider should provide a seizure action plan for any child with a history of seizure activity who attends school or childcare, or who is cared for outside the home while the parents work. Nurses can assist parents in making sure that teachers and caregivers understand the action plan and know when and how to use it. Children who experience refractory or intractable seizures, those that continue to occur despite medical management, should be referred to an epilepsy center for other potential treatments, such as ketogenic diet, vagal nerve stimulation, or evaluation for surgical treatment. A ketogenic diet is occasionally used for children under age 8 who experience myoclonic and absent seizures. This diet involves high intake of fat, adequate intake of protein, and low intake of carbohydrates. Motivation must be high for the family to prepare the food and maintain the child on the diet for several years. Improved seizure control is directly related to compliance with the diet. The most common complications are constipation, hyperlipidemia, and kidney stones. A trial of anti-seizure medication withdrawal is often attempted for children who have been seizure-free for 1 to 2 years, with medications tapered slowly over a period of months. Approximately 65% of children remain seizure-free if they have not had a seizure within 2 years of stopping medication. Criteria that boost a child's chances of remaining seizure-free after discontinuation of medication include easily controlled seizures, normal neurologic and developmental function, epilepsy with no identifiable cause, and no changes on EEG that are characteristic of epilepsy. Every year, approximately 20,000 women with a seizure disorder give birth. With proper care, these women can have healthy pregnancies and healthy babies. However, several special considerations must be given to a woman with seizure disorders when they are planning to get pregnant. One important consideration is the need for women with seizure disorders to discuss with their providers the risks versus benefits of taking certain anti-seizure drugs during pregnancy. Most providers believe that the risk associated with fetal birth defects is minor compared to the potential complications associated with a tonic-clonic seizure during pregnancy. If the pregnant woman has a seizure during pregnancy, it could result in injury to the woman and fetus because of a fall, or it could result in decreased oxygen to the fetus, preterm labor, or preterm birth. In addition, many of these defects can be prevented by increasing the woman's dosage of folic acid to 4 milligrams per day before and during pregnancy. In addition, the risk of hemorrhagic disease in the newborn due to the exposure to anti-seizure medications can be reduced by increasing the pregnant woman's intake of vitamin D during pregnancy and administering vitamin K to the neonate. Women with epilepsy who are contemplating pregnancy should be advised to coordinate their care with their neurologist and obstetrician. Preferably, these providers will already have experience treating pregnant patients who have epilepsy. Both the pregnant patient and the fetus will need to be monitored closely throughout the pregnancy. Any medication changes should be made prior to conception to allow the woman and her provider to determine how effective the new medication regimen will be at controlling seizures without putting the fetus at risk. Once the woman is pregnant, dosages may need to be further adjusted to maintain appropriate drug levels in the blood because blood volumes change drastically during pregnancy. Eclampsia is a seizure disorder associated with pregnancy. Pregnant women with extremely high blood pressure and rapid weight gain have preeclampsia, and eclampsia is simply preeclampsia plus seizures. The seizures associated with eclampsia are not related to a pre-existing brain condition. Epilepsy in older adults is often caused by stroke, Alzheimer's disease, heart disease, tumors, and injuries from falls. However, approximately half of the seizures seen in older adults are cryptogenic, meaning their cause cannot be identified. Epilepsy in older adults can threaten their independence and quality of life by increasing their risk for falls and fractures, forcing driving restrictions, increasing social isolation and depression, and causing low self-esteem and loss of employment. The manifestations of seizures in older adults are often different from those in children and younger adults. Older adults more frequently have focal seizures rather than the classic tonic-clonic seizures. Older adults often present with a blank stare, brief unresponsiveness, language difficulties, confusion, and automatisms such as lip smacking. The postictal phase is also longer in older adults, sometimes lasting up to 2 weeks, with symptoms such as sleepiness and confusion. Older adults with epilepsy have a higher mortality rate than older adults without epilepsy. Because of the symptoms associated with seizures in older adults, seizures are often misdiagnosed as stroke, dementia, or heart disease in this population. Diagnosis is complicated by both comorbid conditions and the fact that the standard diagnostic tool, the EEG, is often unreliable in older adults because many healthy older adults have EEG changes. Epilepsy in older adults is usually controlled by anti-seizure medication. However, care must be taken when choosing the right anti-seizure medication for an older adult. First-generation anti-seizure drugs such as phenytoin, carbamazepine, valproic acid, and phenobarbital have a greater incidence of drug interactions and adverse effects such as imbalance issues and confusion compared to the newer second-generation anti-seizure drugs such as lamotrigine. um, levetiracetam, and gabapentin. Nurses play an important role in the care of patients who have seizure disorders. The first priority is to ensure patient safety during a seizure, accurate assessment and documentation of the seizure length, symptoms, and spread can help determine which type of seizure the patient is having. It also provides ample opportunity for the nurse to teach patients and their support network about seizures, safety precautions, and medications. Observation and patient interview. After the patient's first seizure, obtain a thorough history from the patient or from the parent, the primary caretaker, or witnesses to the event. Take a description of the seizure and its length, in addition to whether an aura was present or whether the patient lost consciousness. If the nurse observes seizure activity, document the time the seizure started and finished, the symptoms involved, whether it was localized or spread or was generalized, whether the patient lost consciousness and for how long, and the duration of the post-ictal phase. If the patient loses consciousness after the seizure, the nurse can ask whether there was an aura and what the patient remembers about the event. Perform a complete physical and neurological examination. Assess and monitor the patient's physiologic status. Observe the specific seizure activity, level of consciousness, vital signs, and signs of hypoxia. During the post-ictal period, monitor vital signs. Perform neurologic checks and ensure safety. Once the patient is stable, a more definitive assessment can be made. Level of consciousness is one of the most important indicators of neurologic function. Remember that a lack of response may be the result of the post-ictal state. Common nursing diagnoses for an individual with a seizure disorder include the following: ineffective breathing pattern, risk for trauma, chronic low self-esteem, impaired verbal communication, and acute confusion. Nursing care for the patient with a seizure disorder focuses on maintaining safety, ensuring a patent airway, preventing or controlling seizure activity, providing emotional support to the patient and family, and administering medications as ordered. Planning must include care of the patient in both the inpatient and outpatient setting. Nurses should help patients and their families find support groups or other available resources. Goals may include the following: the patient will not experience trauma or injury related to a seizure episode. The patient will maintain a patent airway and effective respiratory function during a seizure episode. The patient will experience no or a limited number of seizures through adequate administration of prescribed medications. The patient and family will have an adequate support system in place so that the patient can maintain a positive self-image. The patient and family will be aware of signs and symptoms that are specific to the patient and occur with seizure activity. They may also be aware of any precursors to seizure activity and note them. Even a diary may be used. Another goal would be the patient and family will not experience a disruption of educational, social, or workplace opportunities due to the seizure disorder. Nursing interventions for patients with seizures include ensuring the patient's safety during and after the seizure, maintaining the patient's airway during the seizure, and providing information to the patient and family related to home management of seizures. Ensuring safety for the patient during a seizure is vital to reducing complications associated with the seizure. Nurses can help provide for patient safety by keeping the following points in mind. Place nothing in the patient's mouth during a seizure. Loose teeth may be knocked out and aspirated. Do not restrain the patient during a seizure. This can result in injury or asphyxiation. Protect the patient from self-harm during violent seizures. If the patient is in bed, the side rails should be padded to prevent injury. Children who have frequent, recurrent seizures should wear helmets to protect their heads during falls. All patients with seizure disorders should wear some form of medical alert identification. Maintain the airway. If a patient is having trouble breathing during or after a seizure, the nurse should perform actions to help maintain an adequate airway. Such actions may include the following. Position the patient on his or her side so secretions can drain. Maintain functioning suction at the bedside to clear the airway as necessary. Monitor to ensure adequate oxygenation. Of course, mucous membrane should be pink. The heart rate should be at a normal or slightly elevated rate for age, and the pulse ox should be greater than 95%. Oxygen is usually administered when the oxygen saturation falls below 95%. Take special precautions when administering intravenous medications, diazepam, lorazepam, or phenytoin, for the emergency management of status epilepticus. Give these medications very slowly over several minutes to minimize the risk of respiratory or circulatory collapse.